Good afternoon, everyone. I'm going to be talking about a very important topic, that is mandatory swap and ABOi-compatible transplant counseling before deceased donor kidney transplant registration. So I'll first talk about the growing burden of the waitlist and its consequences, and how mandatory counseling can be a solution to this and how to implement it. So as of September 2024, there are more than 72,000 patients currently on the deceased donor waitlist. A majority of that is 54,000, more than 50,000 patients are waiting for a kidney transplantation. The numbers have increased exponentially from just a couple of thousands a few years ago to what we have right now. And the waitlist keeps on growing. And in the last year only, more than 10,000 new patients have registered. Even our top deceased donor kidney transplant programs, such as Tamil Nadu, Telangana, and Gujarat, are unable to keep up with the growing burden and transplanting only a small proportion of patients on the waitlist. This is India in the global context, data from 92 countries. In this graph, the right side shows the burden of the kidney, burden of the disease, showing patients that are currently waiting on the waitlist or have either died on the waitlist. And on the left, in yellow, are the number of transplants that have been conducted. So broadly, there is a huge gap. In countries like India, there is a short waitlist, but even lesser number of transplants are being conducted. So the burden on a patient waiting for a deceased donor kidney transplant is threefold, and I'll be talking about each one of them. First, there is no national or state level data on how long do these people actually wait. Estimates suggest that patients wait for over 2 to 4 years, and especially patients with blood group AO have even longer wait times. At the same time, mortality is huge. Overall, more than 10,000 patients lose their lives waiting on the kidney transplant waitlist. In India too, there's significant mortality, and more than 1,000 patients have died each year still waiting for an organ. And finally, being on chronic dialysis and waiting for a transplantation is financially devastating for most Indian patients, resulting in catastrophic healthcare expenditure, and they have to resort to distress financing. In contrast, kidney transplantation has a higher upfront cost, but becomes more cost effective within just a year or two. So waiting for a deceased donor kidney transplantation is long, costly, and risky. Yet the kidney transplant waitlist keeps growing. Of course, we have rising burden of CKD, and patients survive better on dialysis. Combined with low deceased donor rates, the waitlist is bound to grow. This cultural hesitation, donor fears, misinformation, and unawareness about alternate options, leaving many patients with the perception that deceased donor kidney transplantation is the only route to achieve an organ. This results in over-registration. So the demand keeps rising, supply remains stagnant, and myths and fears widen the gap. So what can we do about it? Of course, we can raise public awareness. We can delay progression of CKD. We can utilize newer technologies like xenotransplantation and artificial kidneys. But many of these require a change at the grassroots level, are resource intensive, or frankly, too futuristic for Indian scenario. What we can do is optimize what we already have. That is our living donor options. So as many as 15 to 20% of patients listed for a deceased donor kidney transplantation have a living donor who is eligible but is not being utilized. And it is our experience that many of them have ABOi-incompatible donors. So what can we offer them? We can offer them ABOi-incompatible transplantation and kidney pair donation. We have robust data from India now, from the largest Indian multicentric study with a cohort from 2011 to 2022 of ABOi-incompatible transplants, showing that mortality, graft loss, and acute rejection rates are comparable to those undergoing compatible living donor kidney transplantation. Similarly, the largest Indian multicentric KPD cohort from 2000 to 2025 showed graft loss and patient loss less than 10% with 100% donor survival rates. So outcomes for both ABOi-incompatible transplantation and KPD are excellent, yet both are underutilized in India. So before we add a patient to the deceased donor waitlist, we should explore all living donor options. Our primary focus should be on patients who have a willing but incompatible donor. Counseling regarding ABOi-incompatibility and KPD as options will result in immediate transplantation as a living donor option. At the same time, patients with an unwilling donor should also be targeted. This is an opportunity to help address fears, misconception, cultural misinformation, and gender concerns. So how can we make counseling effective? Of course, it should be ideally done during stages 4 to 5, but it should be mandatorily done prior to a deceased donor kidney transplant registration. Once a patient is identified who has an eligible donor, they should be counseled at repeated intervals. Our endeavor should be to include all decision makers, not just patients, parents, spouse, siblings, and extended family members to help them reach a decision. The first point of contact, either a nephrologist or a transplant coordinator, should undertake this counseling, and standardized training modules should be circulated for this. Now, what should this counseling address? Overall donor concerns should be addressed, but as well as risks of staying on long-term dialysis, waiting for a deceased donor kidney transplantation. Available options such as ABOi incompatible transplantations and kidney pair donations, along with their costs, outcomes based on Indian data, and associate risks, as well as approximate waiting time for each of them should be discussed. Like any good counseling, it should be done in native language with simple patient-friendly terms. So this simple change can impact significantly. It reduces waitlist pressure by diverting eligible patients to living donor kidney transplantations. This frees up the deceased donor kidney transplant rates, deceased donor kidney transplant organs for patients with no eligible donors, and to give them a real chance of getting a transplant. It also leads to improved survival due to earlier transplantation. It saves money both for the patient and the health system. It advances equity, and it empowers patients to make informed decisions. So what are the concerns? Will this delay waitlist registration? Counseling should be done at first visit, so it should not significantly delay registration. But even a small delay right now prevents years of unnecessary waitlist burden and chronic dialysis. What about centers that don't undertake ABOi incompatible or KPD programs? So every center, regardless of capacity, has an ethical obligation to inform patients of all available transplant options. It should be up to the patient to take the final decision armed with all knowledge. Of course, it's going to lead to a little bit of extra workload on the staff, but standardized modules can keep it simple and streamlined. Will this pressurize patients to choose ABOi incompatible kidney pair donation? Structured counseling is always designed to enhance informed decision making and not to influence or coerce patient choices. So I propose this recommendation. We urge NOTO to issue a national advisory ensuring that all patients evaluated for kidney transplantation receive structured counseling on living donor options, including ABOi incompatible and kidney pair donations, before being listed for a deceased donor transplantation. A national advisory of this sort will help us in ensuring that all patients are aware of all options before choosing what is best for them. So I'll conclude with this, that waiting for a deceased donor kidney transplantation is long, costly, and risky. Many patients have eligible but incompatible donors. ABOi incompatible and kidney pair donations are proven safe and feasible in India. Mandatory counseling ensures no missed opportunities. It is also an opportunity to address myths, cultural hesitation, and gender dynamics. This policy is simple to implement, it is feasible, it is auditable, it is enforceable. Thank you.